So at the end of today's webinar, you'll be able to describe the common principles of change management and explain the critical importance of engagement and the strategies that increase change adoption. So today, our approach is going to be just the intro and information, then we're going to have some breakout rooms, and we have a wrap up at the end. There's about 5 minutes at the very end to do a short poll because we really do appreciate your experiences and are always striving to make these valuable for you. So with that, we're going to get started. Once again, I'm just going to briefly introduce our panelists. Dr. Baines, again, has an interest in the Medical Home Initiative. She's been working in various projects in Alberta to advance patient medical home. And Dr. Nia, as I mentioned before, is also a family doc. She became a medical officer and joined the Navy at 17. So she's done a lot of different things. She's no longer in uniform, but is helping out in mental health, in precision medicine, and advising the Department of National Defense. So those are our speakers from the panel today, and it's being led once again by Michelle Henney. So I'm going to turn it over to her.
Shelley, and good morning, everyone. It's great to see. Hope you all had a wonderful summer. So let's get started. As always, these sessions follow the Leads in a Caring Environment framework. And today's particular topic of change management falls primarily into the relational domains of leads, which would be engage others and develop coalitions. So you may have seen this statistic before, but research has shown that 2/3 of change projects and initiatives in healthcare typically don't take off, which results in a lot of wasted energy and resources. And according to this paper from the Journal of Advanced Nursing, the primary reasons for these failures include poor planning, unmotivated staff, ineffective communication, and not surprisingly, widespread changes. And I'm sure we can all relate to these. But we also know that change is often necessary. So how can we do our part to make it smooth and successful? How can we help support the people that we work with to accept and adopt new ways of doing things? Change management principles are pretty universal, whether you're supporting team members in a clinic to adopt a new EMR or widespread change like adopting Connecticare. Now, for most of you, most physicians and a lot of healthcare practitioners are familiar with this change management model that was developed by Prochaska and DiClemente, the stages of change model. And this one has been around since the 70s. And as you know, it says that a person's health behavior change involves moving through 5 cognitive stages. So from pre-contemplation, where just beginning to think about it, to contemplation, to preparing for making the change, to then taking action and eventually maintenance of the new behavior. And this model provides direction on how to adapt treatment based on which stage of change the patient is currently in related to the particular health issue. So if Prochaska's model was one of the very originals, there are now many, many models for change management out there. And ProSci's ADKAR model is a popular one and may be familiar to many of you. All of the change management models are similar. They have different nomenclature, but they boil down to very similar principles because they describe classic human behavior when faced with change. And ADKAR outlines that people need to be aware first that there's a need for change to prevent something negative or to adopt something that could be helpful. And then they need to want to work to do that work and expend the energy that would be required to change. And once they have that desire, they need to be able to access the information and knowledge around how to change, and then the ability, the skills and behaviors to actually do it. And finally, there's that reinforcement of the behavior that's needed to sustain the change. And while it's very simple to describe, it can be pretty challenging to make happen, as we all know. So as a physician, you're used to working with your patients for health behavior change management. And you may also find yourself engaging in change management when it comes to those you work with, because both can be challenging. We all know humans are just generally resistant to change. So the people at ProSci did a survey of their practitioners, and they asked them which of the 5 aspects of ADKAR posed the greatest challenge when working with people. And just pop it in the chat, but what do you think got the most votes? So we have awareness, desire, knowledge, ability, and reinforcement. Which one of those do you think was the most challenging, or is the most challenging? I see desire, reinforcement, desire, reinforcement, desire, reinforcement, ability, ability. Yeah. Okay. So we have a mixed bag, but there was one that was far and away the winner, and it was desire. So it's interesting, these complex human brains that we have. It's desire is less tangible, and the others are pretty concrete. So sometimes just getting people to want to expend that energy to make the change is the most challenging aspect of all. Which brings us to a word from Wen about resistance to change.
Thank you very much, Michelle. And it's good to see everyone here. So looking ahead to the medical technology horizon, AI is kind of about to pummel us in the face. Some specialties are more affected than others, but none of us are immune. So if we look at the AI diagnostics world, since the 2010s, healthcare systems, particularly in the United States, have been deploying AI diagnostics and detection in radiology. Despite demonstrated superior accuracy, physicians have reported across the board reduced trust. So how can we hedge our licenses and our patient safety on this black box domain of AI algorithms that the developers can't even seem to explain precisely how it works? The failures to gain the physician's buy-in on the value proposition and the safe adoption of AI diagnostics directly corresponds with decreased desire of adoption. So professionally myself, the more I learn about AI, the more hesitancy I have about the adoption of AI diagnostics. This is a bit contrast to AI scribes. I was like one of the first to jump on board. But the more you know, it seems like the less I can kind of evaluate the risks and the benefits, because sometimes it gets a little bit convoluted and confusing. There's just so much information. Now, if looking at my clinic right now, if the clinic was to impose a specific AI diagnostic tool without discussions or feedback from myself, I probably would have a lot of internal opposition, or it would decrease my desire for this change. But if the clinicians and the allied healthcare staff were involved at the very beginning of that particular conversation, I think all of us will be probably more engaged, more likely to adopt the change, because I would feel like I'm more likely to have all my concerns addressed, and there's a bit more clarity ahead of the change adoption. I mean, this is very similar to what Michelle alluded to about counseling our patients on lifestyle changes, for example. Instead of imposing languages like you must lose weight and quit smoking, peppering this particular conversation over multiple visits, reframing it from the perspective of the patients, and highlighting the rewards from their perspective tend to generate a lot more buy-in and hopefully perhaps over time adoption of new, better habits. So how we package the change matters a lot.
That's right.
Yeah, thanks, Win. And you're describing that science of engagement, which is in and of itself a whole other area of study, and we're going to look into that. In this next slide, there's a video, and I'm just going to give you a warning. We've tried everything we can do to skip the intro, so we're just going to have a couple seconds of an ad, and then we'll get into our video, which depicts this engagement in action. Or maybe we'll.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore, it's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut, and it's not two nuts. 3 is a crowd, and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers, because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is over-glorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
Okay, well, we could spend the rest of the morning unpacking everything that was in that video, but it really was a real-time depiction of engagement theory. So we're going to go into it in a little more depth, but the shirtless dancing guy video that we just watched beautifully showed Rogers' diffusion of innovations theory happening in real time. And according to Rogers' research, when something is novel, when it's introduced, about 2.5% of the population will be what's considered innovators. And they are literally ahead of the curve. That's where that term came from. And whatever the innovation or change is, they've probably already been doing it or using whatever it is in its earliest form. And also, they're usually so far ahead that most people can't relate to them. So then we have the early adopters, who make up 13.5% of the population. They're enthusiastic to try this new thing, that guy that joined the lone nut. And they are much more relatable than the innovators are, and they typically don't need a lot of support or encouragement to adopt, which is why many new things at this point typically fail. They'll fall into what we call the valley of death, because these two groups don't need a lot to adopt. They don't need a lot of support. They don't need a lot of information. And so if we don't then change our approach to suit the next group in line, they're not going to adopt. And again, whatever the innovation or change is, it will just fall into that valley. And this because the next group makes up 34% of people, and they're the early majority. They're interested in whatever it is, but they're definitely much more cautious and they're more skeptical. And they are looking to the early adopters to get their opinion and hear about their experience. They need to know that it's tested, that it's safe, that it's good for their patients. They're typically not saying no, but they need more information, data, and support to say yes. And then once enough of them have adopted, we reach what Rogers called the tipping point, where the early majority are telling two friends and they're telling two friends and so on and so on. And then the adoption just takes off. And then the next 34% are the late majority. And they'll typically join once it's very clear that they're going to be left behind or at a disadvantage if they don't join. Now, the last group, the 16% that are left, Rogers called them laggards, which is kind of a harsh term, but what's important to keep in mind is that this 16% of the population, most of the time, they're at a time in their life or in their career where making a big change, expending that energy to adopt something new just doesn't make sense for them. And another thing to note about Rogers' diffusion of innovations curve is someone can be in one spot on the curve for one change or innovation. They might be a laggard for one thing and an early adopter for something else. So we don't typically have one spot on the curve in life in general. And also people move on the curve as they learn more, as they become more engaged. So someone can move from early majority to early adopter in some cases. All right, this is another more simple depiction of the adoption curve. And you can see the addition of this yellow S curve that shows the rate of adoption. And you can also see that the adoption rate picks up in that early majority when it reaches that tipping point. And the literature on tipping point is it's not super clear. There are many different actual percentages that are listed as when the tipping point occurs. More likely, it's a range of percentages, and it probably depends on whatever the change or innovation is. But the key point is that that tipping point happens during the early majority. So out of curiosity, if we look at the data from Canada Health Infoway about EMR adoption among Canadian primary care physicians, we can see that when EMR adoption was first being promoted, there was low adoption at about 16%, which equates to 16% and aligns perfectly with what we would expect the innovator and early adopter groups to be displaying. And then by 2017, there was 85% adoption, and that number was still the same in 2020. So 15% of physicians had not adopted EMRs over a decade later, which aligns with 16% of laggards not adopting in Rogers' theory. So looking back again at the adoption of EMR over time, if we superimpose that diffusion of innovations curve, we can see how it aligns very closely. And I think we can come to the conclusion that in our situation of EMR adoption, the Rogers diffusion of innovations curve actually did apply. That theory worked. So what we learned from Rogers is to focus our energy on the early majority and make use of the early adopters to engage that early majority group. Early adopters are game to try without a lot of external engagement. The early majority is open, but they need some support, and that includes data and safety assurance from someone they know and trust, and also some step-by-step how-tos and easy to access information and help. So if we can make the early adopters visible, and position them to connect with the early majority and share their experience and guidance, we have a much better chance of avoiding that valley of death. And this applies whether it's a 20-person clinic or a 2,000-person organization. And now over to Andy for an example from her.
Thanks, Michelle. So yeah, kind of on the topic of EMRs, I just wanted to share a change that myself and my clinic, we went through last year. We changed our EMRs, and I'm sure many of you can relate to that challenging and stressful experience. So yeah, we had a big change, and it was from MedAccess to Ava, and it was something we'd thought about for quite a while. And there was people at various stages and in different areas of that curve that are in our clinic. So we really wanted to make sure that we tried to engage everybody and get everybody's input. So one of the things that we did to prepare is kind of make sure everyone felt like they were being included in the decision making. So we had some meetings where our staff and our docs, everybody got together and talked about what they want in an EMR, what challenges they're currently facing. And I think that really helped when we were actually going through the change, because people felt like they were included and part of the decision. One of our physicians actually used this change as one of her PIP projects, and kind of did a pre-survey before the change and a post-survey after, asking people how their workflow has changed, how their stress level has changed, and things like that. And I thought that was really neat. And it also helped make everyone feel like their voice and their experience was important in the change. So little things you can do to just kind of, we're working with people every day. You want to make sure everybody feels like they're part of the team, and that these changes aren't being imposed on them unilaterally. Sometimes there's no choice but to do it that way. But when you have a choice, it's nice to kind of leverage social relationships to try to make that change successful. One of the other things that we really kept in mind is how much change some of the docs at our clinic have already been through. Like when we look at that graph of EMR adoption, and think of some of the docs in my clinic, one of them is for sure 70 because we just celebrated her birthday. And one of them, we have no idea, but we think he's 80, but he has no signs of slowing down. And so we really wanted to make sure that this change was as easy as possible for them. They've been through a lot. They've been from paper chart and probably on 5 different EMRs. So these are people who, they're not afraid of change, but they're also in the final stages of their career. And, going through such a big upheaval is a lot to ask at that point, a lot to ask of them. So we really wanted to make sure that they got lots of support. And sometimes that meant that, I was going in on days off to sit beside them and help them click around, and that it really helped. I think, they felt like we were there for them, and we were kind of making them little cheat sheets and things, and then now they're doing great. So just I think little steps like that to make sure that your team is supported that whole way through can make a big difference. Thanks.
Yeah. Thanks, Andy. And yeah, you're right. That change fatigue is a huge factor when it comes to groups, and it makes engagement that much more challenging. So yeah, great points. And we have one final tip for you from the work of Rogers. So when you can reduce the sense of uncertainty in the early majority, you can positively influence that rate of adoption to change. And Rogers outlined 5 key factors from his research. And the first thing that he outlined is relative advantage. So really making it clear, pointing out to the group how this change will be better than the current status quo. What will make their lives easier about this change? And the next thing is compatibility. So how does it align with my values? Does it fill a gap or a need? How is it going to remove a pebble from my shoe? And then it's about the complexity. So is this change easy to understand and incorporate into day-to-day use? And how so? And then the fourth key is trialability. So can I test it out? Can I try it on a limited basis before I have to commit to anything? And then the fifth is observability. So can I see that others are using it and hear about their experience? And I don't know about you, but I don't book a hotel. I don't book a plumber until I've seen that they have lots of 5-star reviews. So I know for myself, definitely that observability factor is huge. So these Rogers theories, it plays out in our life, and when you look around, you'll see that they actually do hold true even all these years later. So we're going to let you go in and discuss this in your breakout rooms.